Good afternoon, everyone. And for those of you that have been able to find some time in your busy day, welcome. We decided this session that we would do a little earlier. We thought that might be easier. Now, Kathy gives her apologies today. She's away. And as you've seen from the flyer, the topic of the day is managing challenging behaviour. So this is our 6th session of the year, and I'd like to introduce Jim. He's got a tricky surname, so I'll let him introduce himself, and I know that you're going to be learning lots from this session. It's wonderful. So without further ado, Jim, if you want to introduce yourself.
Yes, good afternoon, everyone, and welcome to the Alzheimer's New Zealand webinar, and thanks for the invitation from Alzheimer's New Zealand. So my name is Jim Xu, and I'm a nurse practitioner working for ADHD and specializing in mental health in old age. So my background is I was a new graduate nurse back in 2007, and as a junior nurse, I worked in inpatient for mental health service for older people, and over years, and became a senior nurse manager for 4 or 5 years before I started my nurse practitioner training last year. And I'm a newly graduate nurse practitioner, and so here I am. So the part of my role is doing initial assessment and also provide a bit of training and also support my colleagues and in the team. So let's move on to today's topic. So what's a challenging behavior? And the formal definition is the behavior can be described as a challenging when it's of such intensity, frequency, or duration as to threaten the quality of life at all, the physical safety of the individual or others, as likely to lead a response that are restrictive, aversive, and result in exclusion. And really, in brief, it's the challenging behavior is a behavior that severe enough, frequent enough, long enough, impacting on the self and others' quality of life and safety. Therefore, interventions are often required. So on the other hand, it's important to know that the challenging behavior is the way that clients try to express their unmet needs. It's a sign of distress or suffering or reaction to the stress in the carer. The challenging behavior can increase caregiver stress, reduce quality of life, and increase risk of the hospitalization. And the challenging behavior can also occur with any mental health problem, but it's a common problem in the old people with dementia. The term, the behavior and psychological symptoms of dementia, bpsd, is linked to the challenging behavior, and the symptoms often resolve the challenging behavior. So there are several strategies to manage challenging behavior. So I have concluded here. The first strategy is to stay calm. So while I worked in the inpatient unit, always told myself and my staff, managing self before you manage clients. If the carer is unsettled, for example, like a carer feel like stressed, anxious, angry, irritable, or agitated, so potentially actually impact on the patient presentation, causing a worsening behavior, affect the relationship with clients, and unable to deliver actually intervention effectively. So second strategy is to identify the cause or trigger of the challenging behavior. And the third strategy is observe and listen for clue. And it's important listening to the client, observe their behavior in order to identify the cause and the trigger, if possible, to remove cause and the trigger. It is always important to take care of clients' physical needs, such as basic needs, food, fluid, toilet, pain, any form of discomfort. So there are lots of calming techniques, we potentially can try, such as like hand massage, music therapy, and sensory modulation, etc. We can also try, the distract, and we can distract patient, direct patient with comfort any kind of comfort activity or favorite activity they may like. And very important, always asking for help when needed. So helping others when you can. We're talking about help your colleagues, help someone, having a difficulty to manage, distressed client. So nobody knows everything, nobody can fix everything. So it's okay, ask for help. So collaborative care is important to improve quality of care and to reduce the carer burnout. Lastly, I want to talk about the medications, using the medication to manage challenging behavior. So I will, spend probably 10 minutes talk about pharmacology intervention in the second part of the webinar. So I mentioned the BPSD quite a few times, in the previous slides. And so the basically term of BPSD is behavior psychological symptoms of dementia, refers to the spectrum of non-cognitive and non-neurological symptoms of dementia, such as agitation, aggression, psychosis, depression, empathy, and many more. This slide talk about some of the basic effects about dementia with BPSD. Firstly, up to 90% of people with dementia would develop BPSD at some point during their journey. And secondly, dementia with BPSD can be distressing for patients, family, final, and carers, and challenging for health professionals to manage. So in many cases, dementia with BPSD can be improved with a modification to the patient environment and the behavior interventions. So lastly, antipsychotics are only effective for specific behaviors such as agitation, psychosis. So psychotropic medication are often overused in the management of dementia with BPSD. And psychotropic medication are associated with a significant risk in people with dementia. Researchers and clinicians actually tend to put a BPSD into different categories, helping to understand the BPSD and guiding the BPSD interventions. So here, and there are 5 types of BPSD, including abnormal mood, abnormal thoughts, abnormal perception, abnormal motor function, and abnormal sleep pattern. So abnormal mood include depression, anxiety, empathy, elevated mood, any like affective, disorder. Abnormal thoughts include delusion, suspiciousness, and misidentification, and the feeling of abandoned. Abnormal perception include hallucination, illusion, and abnormal motor function include hypo and hyperactivity, agitation, aggression, and disinhibition. And abnormal sleep pattern including hypersomnia, insomnia, sleep-wake cycle, reversal, and also fragmented sleep. And so next slide, and contain information about BPSD etiology. So I have put etiology in 3 different categories. That's including biological reasons, the previous experience, and non-biological reasons. That would help people to understand the BPSD behaviors and the BPSD intervention. As you can see, the biological etiology, for example, the dementia-related agitation, disinhibition, psychosis are associated with volume reduction and decreased metabolism in parts of the brain. So this is something you can see actually in the CT head scan. And the empathy associated with a small vessel metric disease and also BPSD, they has association with a neurotransmitter change. That's why we use actually antipsychotic medication, antidepressant to manage BPSD. Dementia clients with the premorbid personality tend to respond to the challenge with the exaggerated negative emotions such as anxiety, depression, and anger. Like dementia clients with the premorbid post-traumatic stress disorder might be very sensitive with certain triggers and may be anxious, panic, or agitated when are re-traumatized. And I can give you an example. Actually, just a patient I'm going to see in a couple of days' time actually, and he apparently when he was younger, and he actually spent time in the concentration camp. And recently he got a severe dementia. He was actually sent to a dementia unit. And the environment, actually, he was a lot secured. Of course, he was re-traumatized, you know, and developed lots of BPSD symptoms, you know. That's just typical example of, you know, related to this topic. So non-biological etiology of BPSD included, you know, the problematic caregiver communication styles and the environmental factors. So the environment could be too noisy, or actually is it too stimulating? Sometimes not enough stimulating, actually. And the client's needs are not met due to different reasons. For example, like if a client is Asian, but they're not getting an Asian food, and their needs are not met. And also someone has a special religion, they need to pray regularly, but there's no safe environment for them to pray. So their need also is not met. So clients learn challenging behavior from carers, such as providing attention when the patient calls out. So like if patient calls out, you know, all the time, and the caregiver goes to visit to check on patient every time the, you know, patient calls out, it developed that actually habit, you know. So lastly, patient environment mismatch could also be the trigger for the BPSD, as needs are not met. So the next slide, this slide is about risk associated with the BPSD. So BPSD risk include risk to self, to others, from others, and you know, other forms of risk. As you can see, the risk to self, including the risk of delirium, medical illness, falls, wandering, accidental injury, malnutrition. There's really many more. Risk to others, including verbal and physical aggression and sexual inhibition. Risk from others includes the physical response to intrusive behavior and aversive effect of the interventions, and elderly abuse, which, you know, becomes, you know, slightly more common in recent years, and other risks of carer stress, social isolation, and many more. So effects of the BPSD at aged residential care facility. The BPSD is really common at aged care facility, so it can have a significant impact on the aged residential care. So as a result, people with BPSD have a greater use of physical restraint, greater use of antipsychotics, a negative influence on other residents, higher cost of, you know, the institutional care, and increased stress on the nursing staff. Contributing factors for the BPSD. So as you can see, some of the contributing factors are unmodifiable. So we will have to accept it. There are no intervention that we can change those unmodifiable factors. So unmodifiable factors in this slide include types of dementia, stage of the dementia, personality, lifestyle, genetic makeup, you know, and many more. Some of the contributing factors are potentially modifiable or modifiable that we can work on, especially those modifiable factors. So all of this focus on what we can do, what we can change, rather than what we can't change. So modifiable factors include unmet needs, pain, acute medical problem, caregivers' knowledge, caregivers' distress, over or under stimulation, lack of routines. Potentially modifiable factors include, you know, other medical problem, a neurotransmitter change, a caregiving quantity, and the family dynamic. Now we move on to the second part of this webinar. I'm actually going to talk about a BPSD intervention. So as I mentioned previously, I'm going to introduce BPSD date interventional algorithm. So we start with a D, describe. So we need to describe when actually, you know, the BPSD behavior happened, what are the symptoms, and how severe, and any depressive symptoms, any emotional regulation or dysregulation, any sleep problem, and any safety concern, and what's actually causing the problem, any triggers, and any family dynamics. Then we go to A, analyze BPSD symptoms, and can you explain this BPSD? What have you learned about the patient? What are the contributing factors? Are they modifiable? Then move on to the next stage is a treatment intervention. So we treat modifiable factors, explain unmodifiable factors to caregivers, support caregivers, provide comfort to patient, apply non-pharmacology interventions, and provide pain management, and consider actually the pharmacology intervention. And then lastly, it's evaluation. We need to evaluate the treatment intervention. This part is often missed by the clinician and also by the clinical staff. So we need to evaluate whether actually intervention are actually feasible and effective, and evaluate sleep quality and quality of life, caregiver stress, and unintended consequences or side effects. That help us to adjust treatment plan intervention. So let's go back to the first one. It's first approach to manage BPSD is described. So all of us use the ABC approach. A is the antecedent, B is behavior, C is consequence. So use the ABC approach to describe actually BPSD behavior, and where possible, resolve those underlying factors. If patient is having a pain, and the manage pain. If patient is having a infection, and treat infection. So all of us use a person-centered approach, showing the recognition, respect, and trust. All of the same behavior as a way of communication rather than a problem. Remember, failing to understand the resolve challenging behavior can actually create more challenging behavior. So, and I do actually, I guess over years working in patient, I do see actually some kind of staff actually burn out. Sometimes they just ignore the challenging behavior, end up actually patient become more settled. The second part of the data is analyzed, as I mentioned earlier. So why we need to analyze BPSD and how we analyze BPSD. So it is to establish priority regarding the nature and urgency of the intervention. If a patient risk really high to self, to others, we probably have to intervene urgently. That would guide our intervention treatment plan. But if a patient risk is low or the manageable, and they'll give us a bit of time to know what's happening to the patient, and we don't have to actually to provide any acute management. So, and also is to characterize the symptoms. I tend to use old card. I know probably most nurses are familiar with old card we use for the pain management. But I quite like to use old card actually to characterize actually the BPSD symptoms, and also to review medication, to assess comfort, to review the psychiatric history and the substance use, and to create a baseline. So we use a tool to create a baseline. It's just help us to actually evaluate it in the future, and to understand the patient's background. That can provide a great insight into the potential causes and the solution for the BPSD. So for example, knowing their lifestyle, their cultural, religion, spirituality, their previous vocation, interest, whatever actually important to them, and that's help us to guide the intervention. So this slide is just basic information about don't forget a physical examination and the evaluation, because most time the people with dementia patient with BPSD, they may have a physical health trigger. So there's two identified factors that may contribute to the worsening BPSD, such as delirium, discomfort, or pain, or to evaluate blood, urine, and any other diagnosis, like tests like CT, X-ray. So now we move on to the intervention. So the first intervention for BPSD is all of the environmental approach, such as reducing level of noise and the negative distraction. And often actually I visit clients at the age residential facility, and TV is on, no one actually watching, and and sometimes volume really loud, because some clients may have actually hearing problem, but potentially there's too much stimulation noise for other clients. And also setting the temperature that comfortable and for everyone, considering the patient the proximity to heaters, cold drafts, ensuring adequate lighting, avoiding glare from the artificial light or sunlight, using label and memory aids for objects the patient frequently use. So they tend to, of course, you all know, and the dementia patient, they have, impaired short-term memory. Some of them, they constantly looking for their items. If we use labels and memory aids, for them, actually, that may help the reducing anxiety, reduce the time actually looking for items. Ensuring easy access to the toilet, the regular, toileting, and can help. And also the signage is important. And providing privacy, avoiding overcrowding environment, and also having a clock and calendar and daily schedule to improve orientation to time, and also that encourage them to attend activity. In residential care facility, make a patient surrounding as like home-like as possible, with personal belongings, pictures, photos, items, and offer cultural significance. They are important. Also, having consistent care where possible, and that's important because we hope, and over time, the clients can develop therapeutic relationship with caregiver. And the next intervention as non-pharmacology intervention, which is always the first line for the BPSD, such as music therapy, sensory approach, activity, exercise, meeting individual needs, and developing trust relationship. And so current literature evidence for BPSD non-pharmacology intervention are favorable, but not very strong. So partially because it is very difficult for researchers to evaluate non-pharmacology intervention. Move on to the interpersonal approach. It's very important in managing BPSD. And the skill training for caregiver, it's very important. Improved communication, problem solving, role plays, improved recipient experience. So education for caregivers, activity planning and environmental design, enhance the caregiver support, and self-care techniques. The last part of self-care techniques is very important for the clinician, or the nurse working with dementia with BPSD patient. It's important to look after yourself as well. Now we move on to the pharmacology intervention, and just before I start, going to each medication. So we need to be aware of some of the limitation. So most psychotropic medication are not approved for treating the BPSD. Their use are off-label. So the principle of using psychotropic medication in BPSD is go low and go slow. And also all of us consider actually more benefit than risks. The selection of medication should be evidence-based and target at client's BPSD particular symptoms. All of us consider potential drug interaction, and ongoing monitoring the tolerance and the potential side effects are also important. Psychotropic medication should be limited in time and reduced to stop when the BPSD improve. And some clinicians, they suggest 3 months and start to stop psychotropic medication after the BPSD is stable. And I think the guideline normally talk about 3 to 6 months. And I know some clinicians may actually take a year. Everyone's different. I think if it's safe enough, I think 3 months, maybe start looking at reducing or stop the psychotropic medication if BPSD symptoms actually stable. So let's move on to the antidepressant. So antidepressant are used for depression, anxiety associated with dementia. Can improve cognitive and affective symptoms such as agitation, aggression. So SSI, particularly citalopram, are preferred due to good tolerability and good treatment response. Tricyclic antidepressants are not recommended just due to anticholinergic adverse effects. Mirtazapine actually is commonly used for depression, anxiety, and the nocturnal disturbance. Actually become more and more actually the common at age residential facility by the GPs and NPs. And another reason, because it's probably, the less side effect and safe, and also monitoring potential side effect of hyponatremia and QT prolongation and constipation. So anti-dementia medication, and there are only really 4 anti-dementia patients we use in New Zealand, which are put into 2 categories. The first category is a cholinesterase inhibitor, or we call it anticholinergic medication, which includes 3 donepezil, which most people are probably familiar with, and rivastigmine and the galantamine. So evidence supported using for mild to moderate dementia with negative symptoms such as apathy, depression, and irritability. So memantine is an NMDA antagonist. So evidence is supported using for moderate to severe dementia with positive symptoms such as agitation, aggression, and psychosis. Mood stabilizers are sometimes used for managing BPSD. So there are some evidence for carbamazepine treating agitation in dementia, but really limited evidence for gabapentin, pregabalin, and the lamotrigine. But I have to see actually probably more and more, supporting evidence for, pregabalin for the patient having a, neuropathic pain, anxiety, sleep problem, and sometimes, then the pregabalin can be trialed. So valproate is not recommended, surprisingly, but it's actually used by some clinicians for managing agitation, aggression. And some of my colleagues, they do use valproate for BPSD, but again, that's as last option. So mood stabilizers are in general associated with a severe side effect. So antipsychotic medication, so commonly used for managing BPSD. Risperidone is only one, as I mentioned earlier, approved antipsychotic for treating BPSD. So antipsychotics are effective treating agitation, aggression, and psychosis. Other commonly used antipsychotics are aripiprazole, it become more common, and quetiapine and olanzapine. Haloperidol is used for the treatment of delirium. Not recommended in dementia due to EPSC, according to the guideline. However, it is still used by some clinicians. According to the BPSD intervention guideline, antipsychotics is indicated for the BPSD that are moderate to severe, that impact on the patient or caregiver's quality of life, functioning, or that pose a safety concern, often in conjunction with non-pharmacology intervention. This slide, I put the recommended dose for the commonly used antipsychotic like haloperidol. I know it's really not recommended, but they commonly used. And the initial dose is 0.5 milligram, then maximum dose really up to 2 milligram. Risperidol started with 0.25 milligram and up to 2 milligram. Olanzapine 2.5 milligram started with, and up to 10 milligram. I have to say we do use more than actually the maximum dose. And so sometimes like olanzapine, we do use 15, 20 up to, depends on a patient age, physical health condition, and then also their size, their body weight. Quetiapine started with 12.5 milligram and up maximum dose 100 milligram. Now one of my patients actually I'm using 200 milligram quetiapine, but divided into three doses. And because simply she has a frontal temporal type dementia. She's late 60s. She's very young and physically able. So, and she responded well to quetiapine previously. That's why we just increased quetiapine dose. And she's doing really well. We both discharging her from our service. It's medication, pharmacology intervention is not only about psychotropic medication. Other medication also play an important role here. So that's included pain medication. We often, and put a patient on the regular Panadol, and even they don't complain of pain because we don't know actually. Some of dementia patients, they aren't able to tell us if they have pain or not. and always try regular Panadol and any other pain medication if needed. And also important managing the constipation. Use laxatives properly. Don't overuse them because a frequent bowel motion and also can cause stress to the clients, or diarrhea actually causes stress to patient. And also treating UTI and other kind of infection is also important. Benzodiazepine, and we use probably a lot in New Zealand, but according to guideline, only recommended for the management of acute crisis due to lacking evidence for efficacy. But really, a lot of clinician or lots of family caregiver actually found, oh, this is really helpful for short term. That's probably true because we use lorazepam quite a lot, and that's short acting, and it can help actually during the acute crisis. Zopiclone used for sleep disorder in dementia, melatonin, and effective in treating the circadian sleep disorder. So, and again, some clinicians probably don't believe it. And I have to see the literature supporting, but it's really weak. So other treatment really, as I say, probably many treatment I have actually included here, but I want to mention light therapy. And again, that's for some Downing's, behavior, and also some patients have sleep disorder at the light therapy, and to put patient, make sure patient have enough sunlight, especially during the winter. And TMS is on trial in some countries. ECT is also used for BPSD in some countries, but it's really controversial, not used in New Zealand, I believe. So we move on to the evaluation. So it's always important to evaluate the intervention and the treatment regularly. So, and I guess recommendation, every time you change medication, before you change the medication, you got to, evaluate the treatment, whether it's working or not, whether the patient actually having a side effect or not. So step one is to compare current presentation to the baseline. And step two is to consider risk versus the benefit. Make sure whatever intervention we introduce having a more benefit than risk. And also risk is manageable. Step three is to involve clients, caregivers, and family in the evaluation. It's so important actually, because the caregivers spend the most time with clients. And they are the one, and know actually whether intervention is working or not. And sometimes if the clients are able to tell us, and it's important to include them. Step four is to adjust the intervention based on the evaluation. Look, if the dose is too high, causing the increased force risk, we may have to reduce the medication. Or if if any kind of non-pharmacology intervention actually can cause increased stress, we need to stop that. If any intervention potentially is working for the client, we can reinforce that intervention. And I often get a referral from our psychiatrist and to see the patient at a residential facility and to provide advice on non-pharmacology intervention. So I do tell actually the referral or tell the clinical staff, and I do tell the family as well. So if I provided 10 recommendations, one of them works, it's better than nothing. I'm going to summarize. And so in the management of the BPSD, clinician and caregiver need trying to understand why the behavior is happening and where possible to resolve underlying factors. Be aware that many challenging behavior may only happen once, stop spontaneously. Therefore, no intervention is required in this case. Using the behavior chart recording behavior with ABC approach, if a challenging behavior happens more than twice within a short duration and also severe enough, be aware that the first approach should always be non-pharmacology intervention with modifying the possible environmental and carers factors. Applying person-centered care with a behavior management plan. Be aware the use of medication to control the challenging behavior has to be approached cautiously. And also it's very important supporting caregivers and the interpersonal intervention is equally important. And we know actually, some caregiver at the, aged residential facility, and they, over years, they are burnt out, they move on to different jobs, and just simply, and sometimes they don't get enough support, or they don't have enough training. And sometimes they take personal, and of those, BPSD behavior. And lastly, and it's always evaluating interventions collaboratively and making adjustment accordingly. And I believe this is my last slide, so I'm happy to take some questions.
Okay.
I went very fast.
That was a lot of information, Jim. I've got a couple of questions. What's the benefit of referring someone to mental health services versus just asking your GP? What does the service offer?
It really depends on the GP's confidence or experience looking after the, BPSD, and also a risk level, and also, I guess, what family want. Look, it's no harm sending a referral to our service because we are a specialty service. We can provide advice to the GP, to the caregiver. We can communicate with the family, provide a bit of, the education to the family caregiver as well. And we do very comprehensive initial assessment, including the patient's like personal history, family history, and try to understand the big picture. And which look, GP often they don't have time to, the kid and also the aged residential care facility staff, they don't have time actually to put all together. They know patient well, but they don't have the time probably put all information together. So this benefit, I guess, send a referral to our service so we can look into the details and put all information together and provide a recommendation to the GP, to the caregivers.
Certainly, when I was a facility manager, one of the things that I always encouraged my staff to do was we were able to self-refer. Can we still self-refer?
You can. But
I just found that if there was a pattern of behaviour which was difficult to manage, then it was a good idea to get the patient involved with the mental health service so that in the future, if things deteriorated, you always had another professional that you could call on.
I think the barrier is a lot of family, they don't want their loved one to be referred to mental health. They don't want to be labeled as mental health, Sure. Every time I talk to a patient family, I said, this is like dementia, just like a patient having a diabetes, having a hypertension, so yeah.
My second question is around, if you do the referral, what sort of information do you want the residential care staff to collect that helps with the baseline? What sort of information?
Well, that's the part of I guess the why I'm doing this teaching actually. Use that ABC approach really. What's happening? What was triggers? I try to describe actually behavior, and when, what time of the day, and what happened, how often this is happening, and what actually helped. That's the old card is really important. Like and guide actually the the referral and what happened, the how bad actually, just for example, and the patient become restless enough to go into other people's room, and and we want to know what time of the day is it happening every day, why is the patient new to the environment, or any reason. It's just because family visited recently and they're triggered. So just try to put that to contributing factors if they know, and just to help us to understand, and also like patient had any physical problem, like any pain, any infection, and
deal with it.
So and also the good tool we use actually, we do have a BPSD, a questionnaire, and we often we send to the facility, and after we receive referral.
It is true that most aged care companies have some form of challenging behaviour policies, and some of that involves the collection of a 24-hour wheel. So that would be helpful just to see the patterns of when it occurs.
Yeah, I think the challenge for aged residential care facility is the staffing level. Okay, and I have to see, you know, and the non-pharmacological intervention is very time consuming, potentially, you know, and you need to have probably lots of, you know, staff to trial first. But I think longer term, actually, if it works for patient, and it could be a big save for the facility.
The other thing that I found when I worked in aged care was, you know, when people come into a rest home level care and then their behaviour deteriorates, sometimes they need to be reassessed because they need to have either a stage 3 environment or they need to move to another facility. And that's very problematic too, isn't it? To have that conversation with the family.
Yeah. I mean, my suggestion is to try not to move a patient unless we are clear that the risk is really high. It's become unmanageable for current service, you know, and because we know changing environment can make patient more anxious, more unsettled, you know, they become disoriented to new facility. It's not, you know, but look, we do what we have to do, but try not to use as a, you know, pass that to somebody else problem, you know, as it happens, you know, and facilities say, we can manage this patient, you know, can you transfer patient to another facility? Really, you're passing the problem to another facility.
But I've certainly seen in my travels around clients who were clearly very hard to manage within an open hospital environment, and they didn't have dementia care. So it was actually unsafe for the patient because they were wandering or trying to abscond, and at the same time the care workers were scared of them.
Yeah, just going back, if it's clear, if the client has a problem, it's a mismatched environment, yes, we do. Clearly, that's all you need to do is move a client to a suitable environment. That's all intervention you might need. But yeah.
Yes. And I've got one more question, and that's to do with benzodiazepines, which I know are frequently used. You know, any kind of challenge that the nurses have, quite often the GPs chart that. And I certainly was always worried because they were PRN, and a patient could go from being a little bit noisy or anxious to suddenly unconscious or a history of falls. And yet nobody thought to stop the benzos. It's a worry, isn't it?
Oh, I have to say, actually, the benzo has been used as like a rescue tablets, you know, and
Yes.
for most facilities, you know. And I think in reality, you don't have a GP on site 24 hours. And that's why the GP, MP, they like to chart some PN lorazepam, just to really just help, you know, the clinical staff may need it. And look, the pharmacology intervention I talked in this webinar is a guideline. It's a guideline help us to practice safely. In reality, is a different clinician practice differently, you know. And as I mentioned, as literature is not strong enough to support, you know, most intervention, but there are actually, you know, I guess it's good evidence support, but just not strong enough. That's why clinicians doing slightly different way in clinical practice. In terms going back to the benzodiazepine, you know, and as benzo really used, if a patient distressed, why don't you try some benzo, you know? And you don't want a patient suffer, you know, as both risk benefit. If you have a clear reason why actually you're using, and also you believe actually the patient get more benefit than risk, that's constantly you do that evaluation, you know, and make your clinical decision. And if a patient having a lot fall from the benzodiazepine, you have to review the usage, because benzo, you know, it does increase false risk.
Yes.
Yeah.
I think personally, in terms of safe nursing practice, if you have assessed the client, you know the drug you're giving, and you see a benefit, then that's good. You've documented the reasons, and that's good. I worry more about people using it like rescue remedy because they want a quiet shift.
Yeah, well, my advice to, especially to the juniors nursing staff, is make sure you know why you're using that medication, PI medication. Don't copy other staff. The other staff use that medication. You need to know what is this PI medication for, what symptoms. You use the lorazepam probably for agitation, for anxiety, and but if someone like for example, I don't like actually staff using the PM lorazepam just for wandering behavior, because wandering is perfect normal.
Yes.
Unless if the risk is really high. For example, they go into other people's room, having causing the conflict between the residents, you may have to use it. So really make sure you know why you use the PM, and also use it for what purpose.
Well, and really, just to finish up, we were talking before the session just about the stresses that nurses face in aged care. They often have 20 or 30 patients, and if someone has challenging behaviour, it can be like a catalyst for a whole noisy, difficult shift, and that causes a lot of stress on the RNs and on the care workers. So for those of you out there who are working every day with this, our hats are off to you. And there's going to be more and more of dementia. So it's really about learning our assessment skills, our managing of our ward environments, and using all of those other members of our team so that we can have person-centred care and a settled environment. And that would be what we're all looking for.
One thing I guess I want to mention again as about the interpersonal approach. I found actually lots of clinicians at aged residential care facility, because people are doing shift work, they don't really communicate with each other what works, what actually didn't work. Yeah. It's learning from each other, supporting each other is so important. And also, I guess for the message for the public, for the managers as well, it's important actually provide a regular training to your staff. It's
Absolutely
important,
Yes. Well, that's all the questions. Jim has kindly offered his slides, so that when you if you wish to have a copy of the slides, you just need to email me, and I'll be sending out certificates in the next few days. So for those of you that have attended, thank you, and I hope you got something out of it. There will be other people, of course, who will watch it on recording. So that's all from us today. Thanks very much, Jim.
Thank you. Bye.